Who's taken over the esophageal committee?
Danielle.
Melina.
Yeah.
Okay. I thought she was all done with the SACT, but clearly not.
No. So do you want to go ahead and start yours?
Yeah, Beverly will put that slideshow up that she has. While we work on getting that slideshow up, I'll just thank everybody for coming tonight and logging on and joining us for an SSAT webinar. This webinar is hosted by the esophageal subcommittee of the SSAT. And Dr. Iyazi, I want to thank him also for putting together really an outstanding lineup of thoracic and foregut surgeons to talk about some interesting and novel technologies to help us make some of these tough clinical decisions in our patients. What's special about this event is it's the first time that one of these webinars is sponsored. So I'd also like to thank our sponsor, Castle Biosciences. I also do want to mention that our webinar attendees and speakers had no idea who was basically had no influence on their talks as they didn't know who was sponsoring this. And so I'll go ahead and turn it over to you, Dr. Iyazi. I think we have a quick slide and a quick video that we'll pull up, and then
All
we'll
right.
get going.
Beverly, you are muted.
Hey, Beverly, are you able to unmute yourself? Sorry, we're not getting any audio from the Tissue Cipher. Well, given the technical difficulties, maybe we'll play this at the end unless we can get it worked out.
So we're going to show this again before our Dr. Cole gives us the talk. So hello, everyone, and welcome. Thank you for joining us for today's SSCT webinar on the modern management of Barrett esophagus. My name is Shahin Ayazi. I'm a foregut surgeon from Pittsburgh, and I'm pleased to co-moderate today's session with Dr. Vingeshwaran from University of Chicago. Over the next 90 minutes, we will discuss three important and evolving aspects of Barrett's care: risk stratification and prediction of progression, decision-making regarding surveillance versus intervention, and the role of antireflux surgery in influencing disease trajectory. We have an outstanding panel of experts who will share their perspective and practical insights on each of these three topics. Before we begin, I'd like to acknowledge Castle Bioscience for sponsoring this educational webinar. The content and opinion presented today are those of the speakers and moderators and do not necessarily reflect the view of the sponsor. For those in the audience, please feel free to submit questions throughout the presentation. We will save them all for the discussion period at the end of our discussion, and we do our best to address as many as possible. With that, I'd like to introduce our first speaker, Dr. Jen Cole. Dr. Cole is an advanced endoscopist at UCLA and a nationally recognized expert in Barrett esophagus and esophageal neoplasia. Her work has focused on risk stratification, early detection, and advanced endoscopic management of Barrett esophagus, making her uniquely qualified to discuss the evolving role of clinical and molecular biomarkers in guiding patients' management. Jen, thank you for joining us. The floor is yours. And we're going to show the video at the end of 3 talks.
All right, great. Thank you so much. Thanks, Dr. Ayazi, Dr. Vigneswaran, for the invitation, SSAT. It's great to be here with this excellent panel. So I'm going to be talking about who progresses and how do we use the tools that we have to try to prevent cancer in patients with Barrett's. We know that Barrett's progresses stepwise, non-dysplastic to indefinite low-grade, high-grade, and cancer. And Barrett's affects maybe a few % of the US population, but that's still many, many millions of Americans. And the reality is that most patients with Barrett's have non-dysplastic disease, and most of them will never progress. But the current way that we do surveillance sort of treats most patients the same. And this is probably not efficient or cost effective, especially because the rates are extremely low in non-dysplastic, less than 1% per year, and a little bit higher in indefinite low grade. So what are the predictors of progression? So we have all these clinical predictors that are very similar to what we think of as the risk factors for Barrett's esophagus. And that's sort of the exact same predictors that have been tested. So GERD, age, sex, race, obesity. And so some of the data that led to how we understand the value of these clinical predictors for who's going to progress. Well, this was a meta-analysis from 20 studies through 2016. And you can sort of see some of these signals on the left. So it looks like low-grade dysplasia, so certainly higher histology, smoking, potentially a little bit of a signal, male sex over female. Those seem to be having, higher odds ratios to be associated with progression to high-grade dysplasia or cancer. And so that and some other studies around that time, 2016, 2018, led to the development of the progression in Barrett's score, which is a great idea. You take clinical risk factors, you have a way to sort of weigh them, you incorporate endoscopic data like dysplasia, and you create a risk score. And although this is a great concept and you end up with a high, intermediate, low, the reality is that this has never been incorporated into clinical practice, right? These risk scores, even though, it seems like we're still coming up with more and more of these every day, they need to be externally validated, tested, used. And for some reason, as robust the data was, this hasn't really caught on into clinical practice. And over the last few years, we've actually seen sort of a resurgence of these meta-analyses, really trying to look at all these different potential risk factors. So this was a recent meta-analysis. What about obesity? How does obesity affect the rate of progression in Barrett's? So 20 studies, 38,000 patients, and they found that each 5 kilogram increase, each 5 unit increase in BMI was associated with a 6% increase in the risk of malignant progression. Okay, so obesity may be a risk factor in progression. And for whatever reason, they didn't actually appreciate much of a difference between males and females. And that's potentially what we're starting to understand a little bit more. Certainly it's still higher, but this was actually an individual patient data meta-analysis that was published also this last year that looked at non-dysplastic progression risk in males versus females. And although the hazard ratio was 1.44, so males still progressing more than females, the sex differences are probably smaller than previously reported or appreciated. And in fact, if you look at the time to progression, it is shorter in women. So more understanding of sort of how do these affect progression. And then certainly segment length. I think this is where we have the most data. And these data go back to 2019, 2020. And, I think essentially what we've seen is that increasing length of the Barrett segment has much higher odds ratios for progression. So 2.3 for segments 3 to 8 centimeters. That odds ratio of 4.3 is what we typically cite when you're greater than 8 centimeter. That was the Swedish cohort study. And then the US, it's the same data, right? The annual progression rate is much higher for long segment. And there's something intuitive, like more Barrett's, more opportunity to have those cells turn cancerous. But I think, there's certainly also cases that progress that are short segment or ultra short segment. So we take this for what it is. And so how did our guidelines incorporate all of this information? Well, most of our guidelines on surveillance just recommend, surveillance for non-dysplastic Barrett's. All those different risk calculators, risk scores, all those tools that we just talked about, they never have been incorporated into the guidelines, which makes you wonder why, and probably because the data just isn't strong enough. So they're not incorporated. And essentially what we do is we do stratify by segment length, so that I think ACG 2022 was the first time that appeared. And honestly, histology has remained the best prognostic indicator of progression. So that is also very problematic, right? So we're saying that the best thing to use is histology, but dysplasia is a big issue, right? It gives me this headache. It's overcalled. Dysplasia versus inflammation is very challenging. There's high inter-observer variability among pathologists. And we actually know that low-grade dysplasia, that's called, when it gets re-reviewed in sort of expert pathologists or centers, it usually gets downgraded. And so if we're saying that, our best way of identifying progression is histology, and this is what we're relying on, this is a big issue, right? We're over-treating and we're probably missing progressors. But for some reason, our surveillance has still been somewhat effective, right? Prior observational data has shown that there's still mortality reduction from surveillance. Again, this is meta-analysis from observational data. And the thought here is that whatever we're doing, still there's an opportunity through surveillance for early detection and curative therapy. And especially in expert centers where potentially better qualified or better trained to detect dysplasia, to do, appropriate biopsy sampling, whatever, that expert centers with trained endoscopists, you can certainly actually affect disease-specific mortality. So, but then we recently got the results from the BOSS trial, which I think made a lot of people question. And so I'm not here to talk about whether surveillance does or doesn't work, but the reason I bring this up is because we are talking about who's going to progress, right, from the non-dysplastics who we put into surveillance. And so we have to have an understanding of how we can identify the patients at highest risk so that our surveillance is effective. And so the results from all of these studies really make you wonder, well, who is it progressing? And what are the issues and the limitations with our current surveillance that sort of these clinical factors have really never panned out? So certainly, quality endoscopy matters. Seattle protocol misses dysplasia. Histology, we said, is the gold standard, but it's imperfect. Surveillance intervals aren't always followed. And then I think the biggest issue is really that the risk of neoplastic progression is variable. And so one of the main reasons why I think we have to work on surveillance and optimize it, not just, the same reasons we've needed to for the last few decades, but really today, is because we're in the era of new screening. And so if our goal is to expand the screening population, to bring more people into, whatever it is, whether it's endoscopy or non-endoscopic tools for screening, we are going to need better risk stratification tools. We're going to need to be able to use our resources more efficiently and effectively to be able to say who has a new diagnosis of Barrett's and how often should they really get their follow-up procedure. I'll just show a quick case that sort of exemplifies some of these important lessons. So this is a 90-year-old who was referred for Barrett's with low-grade dysplasia. He presented, first of all, he has all the risk factors for Barrett's and esophageal cancer. And so probably 40 years too late for his endoscopy. He had a large hiatal hernia. He had a long segment of Barrett's. One jar was taken, low-grade dysplasia. So many opportunities here for improvement. So use of Seattle protocol could have been more biopsies. The pathology was not re-reviewed and he was referred for ablation. And I think a lot of people might say, well, wouldn't it be great in this 90-year-old who has an option, right, between what to do for his low grade? Wouldn't it be great if we could actually risk stratify, because he might not progress over the next 5 years or, the rest of his lifespan. Whereas if we knew he was a high-risk case. But I think part of that just comes from sort of doing all the things up front. So what I talked to him about is just starting with a repeat sort of upper endoscopy to actually risk stratify him. And so he had a large hiatal hernia, his esophagus, he didn't have any esophagitis, he had long segment, but there was some concerning nodularity. And so we had had a discussion in advance about what the about what the plan was, and not necessarily planning for RFA at all, mostly planning for repeat biopsies. And in fact, ended up seeing nodularity, doing a band EMR, and it turns out he had high grade. So this is not a 90-year-old who progressed from low grade to high grade in a matter of 4 months waiting on a referral, right? This is really a case of missed prevalent dysplasia. And so that is something that we have to really face head on when we talk about who's progressing. We have to not miss high-grade dysplasia, especially up front in the index endoscopy. These are just 2 studies, one from the Australian cohort and then follow-up from the Dutch cohort, that really show the exact same thing, that when patients come in with a diagnosis of low-grade dysplasia, first of all, not all of those cases end up getting confirmed to in fact be low-grade dysplasia. And then of the sort of remaining cases, there's a large proportion of them who actually, if they get confirmed to be low grade, they go on to have usually an EMR or some sort of endoscopic therapy, and they'll turn out about a quarter of these cases to have high-grade dysplasia. So this issue with low-grade dysplasia up front and thinking about how to risk stratify somebody with low grade, we have to even confirm the diagnosis first, right? Nearly 25% of these patients have prevalent high grade. And so I'll just mention post-endoscopy esophageal cancer and post-endoscopy esophageal neoplasia. So this is high-grade dysplasia or cancer that's detected before the next recommended surveillance endoscopy in a patient with non-dysplastic Barrett's. Again, a patient who you apparently, you think that he has a low risk, right? You say that this patient with non-dysplastic can wait 3 years, but then in that interval develops high grade or cancer. And the thought is that these are likely prevalent neoplasia and probably missed lesions rather than them being rapidly developing. So if we flip the script and we move this from limitations in our surveillance to really opportunities in surveillance, I always include any talk on Barrett's esophagus with just a plug for a 10-step approach to a high-quality exam, because this really makes all the difference, right? A lot of the sort of the clinical factors, the endoscopic factors, the biomarkers I'm going to mention in a few minutes, all of that still requires a high-quality exam. And so we have this nice different picture descriptions about how to do a best practices using a CAP, using all of your landmark identification, using virtual chromoendoscopy. And this is really what it takes. PROG classification, standardized reporting systems, even Seattle protocol. This is all required to as any and Barrett's endoscopy. But other opportunities, for Seattle protocol, we may have some new technologies. We talked about histology, but now we're really going to move into this issue with the risk of neoplastic progression being variable. So if clinical and endoscopic factors aren't really adequate and aren't really enough, I went through most of them, but there's so many different studies on PubMed about many other types of things, like all different kinds of possible things, because everybody's looking for what is that one thing that patient has that will predict progression. But we have some really exciting new precision surveillance molecular markers that can be helpful. And I kind of think of these as beyond histology, pre-histology, post-histology, despite histology. They're certainly adjunctive. They're not a replacement for histology, but they offer some useful risk stratification. And I think the most important part of this is that it's really individualized. So we'll talk about P53, tissue systems pathology, 9 or TissueCypher, and maybe some other new approaches. So P53 is a biomarker and for progression, and aberrant immunohistochemistry staining can really be overexpression or it can be loss of P53. So there's 2 different ways that this can manifest. And so this is inexpensive. This is something that can be stained by your pathologist. There is some skill or subjectivity to how this is interpreted. And so, of course, inter-observer variability comes into play again. And they have many years of this being studied. So this was, I think, one of the first meta-analyses from 2019, looking at a group of case control studies and a group of cohort studies, and really finding that having aberrancy or something abnormal with the P53, there was a 3.4 odds of those patients progressing to high grade or cancer, with a relative risk in the cohort studies of 17. So these are pretty significant indicators of high risk disease. The recent meta-analysis in 2026 that was just published, this was actually, I think, what was used to inform the Barrett's AGA guideline. So this was sort of an updated meta-analysis looking at P53 as a tool to stratify. So 27 studies, about 20%, and that seems to be what typically happens. About a quarter of people will have this aberrancy. And looking at, different grades of dysplasia, so non-dysplastic, indefinite, low grade. And what they found were impressive relative risks. So the relative risk of 10 for the low-grade dysplasia and 3.3 for the non-dysplastic, and really showing that having aberrancy in the P53 does predict progression to high grade. And here's some of the diagnostic characteristics. Specificity and negative predictive value are very high. Sensitivity and positive predictive value, there's still room for improvement, and there's still no recommendation for this in the guidelines. And then this was just I just saw this was just published. And I think we're always thinking that low grade is our best predictor, right? Histology. And so this was the first time that P53 was compared to low grade on sequential exams, 960 patients. This was the ProBar study group. So these are from expert centers in the Netherlands. And they looked at over 6 years of follow-up. A small percentage, 8%, developed high grade. And essentially, similarly, a quarter of these patients, what they're seeing is that P53 is strongly associated with the risk of progression, with a hazard ratio of 20. And low-grade dysplasia had no association. So this is a signal that not only is P53 giving us a good signal here that the hazard ratio of 20 is pretty significant. If you're one of those 24% of patients with that aberrancy, there's a high chance of progression. It's also equally compelling to see that low grade really had no association on repeat exams. And then also patients with normal P53 had excellent progression-free survival, again, really speaking to that negative predictive value. So that's P53. Now I want to talk about tissue systems pathology 9 test, or TissueCypher, by Castle Biosciences. So this is a really complex, elegant assay that uses many different biomarkers. So 9 different biomarkers. As you see, P53 is one of them. And you recognize probably some of the other things involved here, like HER2, COX2. These are different biomarkers that are involved in loss of tumor suppression, cell cycle control, angiogenesis, the immune system. And so what the TissueCypher test does is it takes these 9 protein-based biomarkers in the context of cellular structures, multiplex immunofluorescence is performed, and you get a 5-year probability of progression. So this is a commercially available test. It's performed on esophageal pinch biopsies, no blood test, no additional collection required. It's on the routine pinch biopsies that are taken through Seattle protocol. And the specimen is sent to the lab and they run the immunofluorescence, and then they use this whole slide scanning, AI-driven image analysis to really extract the 15 features that are most associated with progression. And what you get after that is a clinically actionable result. And essentially, you get a 5-year probability of progression with a risk score of 0 to 10 and a risk class of low, intermediate, and high. TissueCypher was first developed in 2016, and so all of the body of literature that has been published since then has really grown on, like the body of literature has really built on the exact same tests. So all of the data really stands because there's been no changes or modifications. The original sort of algorithm and test have been locked. So these were some of the validation studies, initial validation that compared non-progressors to progressors. And you see on that right column in the first study by Rebecca Critchley's group in 2016, hazard ratio of 9.4. So if you have a TissueCypher score that is high compared to low, the hazard ratio for progression was 9.4. The second validation study, they actually had expert GI pathologists confirming the low grade, and similarly findings that they identified high-risk TissueCypher score associated with patients had a higher risk of progression. What was interesting about that study was the odds ratio of 46 for prevalent disease. So I mentioned before that there's this issue of missed dysplasia or peak or peen. And certainly if we want to understand how to better risk stratify who's going to progress, we have to make sure that we're addressing who today has dysplasia. And so I think TissueCypher as a test also should alert you that high-risk test, it may not just be that this patient has a high risk of progression, but they may also have prevalent disease. And then the next few studies, additional validation studies, independent studies that were performed showing similarly high hazard ratios. I'll just highlight in that third row, the negative predictive value of the test is 96.4, which has even been sort of higher on more recent meta-analyses. And then in the final row here, the retrospective analysis of the SURF trial, that it actually outperformed pathologists predicting incident progression from low grade. So again, we're seeing signals here that this molecular markers may be better than histology. And so the actionable results from TissueCypher, the way I think about how you handle a low risk score, these are patients who remain in surveillance. 3 to 5 years, you're reassured, right? The negative predictive value is high. Whereas a high risk score should prompt you to do endoscopy surveillance sooner, make sure there's no prevalent dysplasia, or potentially escalate to prevalent dysplasia. And I just want to show this pooled data because it ties into the first part of the talk, which was clinical predictors. Didn't really pan out. Well, this is actually, I like that in this study, they actually looked at how does TissueCypher biomarker compare to clinical features. Well, when they looked at all the non-dysplastics, did age matter, hiatal hernia, segment length, not even really, sex, none of those things actually were helpful in predicting who would progress, but the TissueCypher score, high risk versus low risk, was most helpful in predicting progression. And the final slide related to the TissueCypher data is looking at what happens in the real world. This was pooled analyses from 699 patients. Typically, we have this bucket of low-grade, indefinite, non-dysplastic patients, and their curves look really similar, right? They're kind of overlapping. You don't really have any risk stratification. Maybe as you move to the right, you get a little bit more risk stratification just by having your expert pathologist. But when you add in TissueCypher to these almost 700 patients who had a high-risk TissueCypher score, 7.8 times higher risk, were patients were more likely to progress. And so we're going from really no risk stratification to being able to pick up 62% of our progressors. And so we're increasing our ability to identify those patients. The GI Society guidelines have not endorsed or said that we should not use these. And I think there's a lot of evolution we're going to see in the next year. And then the last slide I'll show, which is from the UK, and it seems hard to imagine doing this in the United States, but there is an opportunity with sponges and non-endoscopic screening to also use this as a biomarker for surveillance to tell us who's, to sort of use P53, but on a non-endoscopic test. So imagine not just having to do this on your endoscopy and biopsies. This was a pragmatic trial where they took patients with non-dysplastic and they said, you get the capsule sponge test, and if your biomarkers are negative and if your clinical factors are low risk, you don't need to have this test repeated. You don't need to have an endoscopy. You can have another sponge test. And if you ended up with somewhere in the middle, maybe you would get an endoscopy. And if you came back with high risk, you would get an endoscopy. So interesting to kind of imagine using these other tools. So the takeaways, most Barrett's patients will never progress, but we should definitely do what we can to find the few who will, because those are cancer lives saved. Clinical predictors are not so useful. Segment length and histology seem to be the most useful, but I think are clearly flawed. And I think we have really compelling data coming from our biomarkers. So even P53 is low cost, still needs to improve sort of some of the performance characteristics. TissueCypher is, it's a validated test, it's objective, it gives you personalized risk, it's actionable, and it's being used in clinical practice. And then I think we have some non-endoscopic tests with biomarkers coming down the pipeline. And the other thing is that longitudinal risk stratification is something we're going to have to think about because risk is likely not fixed. And so these are tests we may need to continue to do at different intervals because probably the risk changes. This is my final vision for Barrett's esophagus widely. So I think we start with the general population in a preclinical setting, risk prediction tools, electronic health record to really identify who is at risk. We use our screening tests to really narrow that down to who gets an endoscopy. And those patients are then risk stratified with all of the molecular markers that we just talked about and all of the different characteristics, and hopefully we prevent a cancer. Thank you.
Thank you, Dr. Cole. I appreciate it. We have a quick video that if Beverly can show the video for us, I appreciate it. Also, for those who have any questions, please submit your questions under Q&A. At the bottom ribbon of the Zoom, there's a More section. Click on that and you can submit your questions directly. Thank you.
Non-dysplastic Barrett's is obviously caused by reflux. We know from previous studies that about 15% of all people with reflux will develop Barrett's, the majority of which are going to be non-dysplastic Barrett's. Some of these patients, or a few, will progress to cancer, but ultimately finding or identifying those patients is a little bit like finding the needle in the haystack. What TissueCypher brings to the table is the ability to help us predict who's at risk for progression. I'd just like to give one example. 60-year-old lady comes in with a long history of having reflux problems. She's got known Barrett's. She comes to us. We do TissueCypher on it. It's only a short little segment. She doesn't meet any of the clinical characteristics for somebody that's at risk. It's non-dysplastic. TissueCypher comes back at high risk. We didn't quite believe it. We were a little concerned because it was such a short segment of Barrett's, so we decided to bring her back for another endoscopy to do more thorough biopsies. Again, this is a high-risk patient. We take those biopsies, and lo and behold, it comes back as invasive cancer. We couldn't see it. You couldn't see it with the naked eye. And at any other place without the utilization of TissueCypher, this lady would have been told to come back in 5 years. Well, she would have been back before that because she would have had an obstructive cancer in her esophagus. But this allowed us to pick it up at an early stage 1 disease.
Okay, I think say thank you to our sponsors once again. And I have the pleasure of introducing our next speaker. Dr. Melissa D'Souza is a foregut surgeon at Hoag Health System, and she leads as the director of the foregut clinical research program there at the Hoag Digestive Health Institute. She has particular special interest in Barrett's esophagus and esophagogastric malignancies, and so we're very excited to have her talk and participate in this webinar. Thank you, Dr. D'Souza.
Thank you so much. It is really such a pleasure to be here. Hard to follow Dr. Kolb and all of her expertise. So let me see if, there we go. So I'm kind of taking over the helm in this vision that you see of Dr. Kolb, where we're going to find the right patients and we're going to screen them and get them in for appropriate surveillance. Well, where are we going to go from there? And I want to bring us back to the whole point of this, right? The reason why we look at Barrett's is because esophageal adenocarcinoma is on the rise, and it is incredibly fatal. So almost 22% of patients, if they're lucky, will make it to 5-year survival, and the rest of them will not. And since Barrett's esophagus is our only known precursor of esophageal adenocarcinoma, we need to catch it at the right point on this timeline. You start with GERD, we get to Barrett's, and then we get to cancer, and we know that multiple different things play a role. Acid, deoxycholic acid, which is bile, epigenetic triggers. But the annual risk of progression to adenocarcinoma from Barrett's is only 0.5%. Now, if you bump that up to people who now have dysplasia, high-grade dysplasia, the annual risk of progression to cancer is 6 to 12%. And again, very fatal. We can intervene here in this dysplasia period and in these stage 1 cancers before they get to this abysmal sort of 5-year survival. So I want to highlight that our surveillance is going to allow for that dysplasia detection and an opportunity to treat, because dysplasia is going to then drive our management of these patients. And finally, failing to control progression of disease is going to require escalation. So surveillance to detect the dysplasia. Well, this comes back to what Dr. Kolb mentions of if we find patients in kind of this early stage 1 disease, if we are basically stage shifting them, their overall survival is significantly improved. We're keeping them out of the cancer range. And as she mentioned, the best way of actually finding the dysplasia when you're doing this surveillance is to have a protocolized technique by a high volume endoscopist familiar with Barrett's, who is making careful determinations. So this is the 10-step technique. I like this nice 5L technique. We all know as surgeons, the simpler, the better. Make it easy for us. And to make it easy for us, this is going to be us identifying our critical landmarks. Where is the GE junction related to the squamocolumnar junction? Is there a hiatal hernia? What is the anatomy we're seeing? The length of the columnar line segment, our Barrett's we're looking at, documented in a standardized fashion. So we use the PROG classification, that circumferential and maximal extent, in order to give that. We are looking at clean mucosa, a cap to aid if you need to, high definition endoscope, using both white light and digital chroma endoscopy. And we are taking our time, at least 1 minute per each 1 centimeter of columnar lined esophagus. We're documenting any lesions we see in a standardized fashion, even as we're intervening on them. And we're getting multiple levels of biopsies. We are using the Seattle protocol. We are using adjuncts, Watts, confocal, endomicroscopy AI if we have it available. So that way we are adequately sampling this segment. And so again, these very basic principles: high quality endoscopy, nice clean tissue, chromoendoscopy, so you can differentiate between kind of abnormal submucosal vessels in areas that could look like dysplasia. Taking our time, a centimeter is 1 minute. You have to spend at least 1 minute per each centimeter. Documenting appropriately using the PROG classification, the Paris classification if you find lesions. And I cannot stress enough the Seattle biopsy protocol. So every visible lesion is targeted, always. And then additional 4-quadrant biopsies every 1 to 2 centimeters, 1 centimeter particularly of prior dysplasia. And this comes from the premise of if we can sample it, then we're more likely to detect areas that could not be seen by the naked eye. Seattle protocol is going to significantly increase detection rate of both prevalent dysplasia and then incident dysplasia that develops. Our challenge is that we don't consistently follow this. As we heard from Dr. Kolb, we miss disease. We're not actually capturing it. The example she gave, that 90-year-old gentleman who had 1 jar of biopsies in a 9-centimeter segment of Barrett's. And the longer the segment of Barrett's is, the less likely we are to actually get appropriate biopsies. But this is critical. Because, as Dr. Kolb also mentioned, post-endoscopy, esophageal carcinoma and neoplasia, 21% of patients will be found to have who have low-grade dysplasia will be found to have high-grade dysplasia or esophageal adenocarcinoma within that period of time that they were otherwise going to see them. And I'm sorry, I've got a little weird overlap over here. But these subtle lesions, these early lesions, insufficient biopsies is how we end up missing cancer and missing high-grade dysplasia. So 1/4 of patients with low-grade dysplasia actually already have cancer or high-grade dysplasia, which will imminently become cancer and can't wait an additional 3 to 5 years for another biopsy. Surveillance frequency. Now, this is something we also struggle with. We're still working a bit on a consensus. For those of us who deal with Barrett's a lot, it's pretty critical to repeat an endoscopy within the first year. And this again comes from those missed cancers and missed dysplasias. High quality exam, if not performed accurately, we're going to miss something. So the EGD in the first year is just to rule out prevalent disease, not new disease that is showing up, but maybe a flat little sort of lesion that you didn't see will become more prominent within a year. Then endoscopy every 3 to 5 years. We can use length of Barrett's maybe to drive us. Again, that's a risk factor for progression, so we may survey a little bit more frequently, using biomarker risk stratification. So if you have somebody who they get a TissueCypher exam, they have very high risk for progression, 27% risk for progression to high-grade dysplasia or adenocarcinoma within 5 years, you probably want to bring them back sooner than that in order to be able to look for any developing disease that we can intervene on endoscopically. And again, as Dr. Kolb mentioned, the biomarker risk stratification hasn't quite made it into our protocols for surveillance, but we need to be thinking about it because these are the patients at highest risk for progression. So Dr. Kolb also was very generous in not wanting to talk about the BOSS study and about the pros and cons of surveillance, but I am going to talk about the BOSS study because this particularly troubles me when we have the discussion about, well, does surveillance matter? Now, for those of you who are not as familiar with this, so this randomized controlled trial set people into 2 arms, either every 2 years endoscopy or as needed, had symptoms. All patients with non-dysplastic Barrett's at the start of the trial, and they followed them for 10 years. They found there was no difference in overall survival or cancer survival, whether they followed everybody at 2 years with endoscopy or just said, hey, come get an endoscopy whenever. And so the takeaway for some people was surveillance doesn't matter. But really does it? So looking at the difference between the 2 groups, the finding of these lower grade dysplasias were when we saw people in surveillance more frequently. Adenocarcinomas, they saw in both groups with that progression, but by the time you get to more advanced adenocarcinoma, that is not actionable from a scope. We aren't preventing progression. And mind you, other limitations with this, more than almost a third of the patients in the 2-year surveillance arm were removed from the study protocol because of multiple reasons. Patients wanted to have more frequent surveillance, didn't think it was safe to continue at the rate they were, especially once dysplasia was found, because those patients then needed more frequent endoscopy. Also, during the time of this study, we had significant advancements in endoscopic eradication therapy, both in the guidelines and in the practice. So we can do a lot more through the scope now than when the study was started. The other issue is the cancers they found. Lower stage cancer, T1A, can be removed endoscopically. Endoscopic eradication therapy, highly successful, found predominantly in the 2-year surveillance group. Surveillance worked. Patients with T1B typically requires esophagectomy. Those are patients that were typically coming in with symptoms. And the most critical part of this is at the very end of the trial, they offered everybody who had not gotten a single endoscopy, an endoscopy just to check. They did, in fact, find new cancers and high-grade dysplasia at the end of the trial, and those patients were not included in the results that were presented in the other table. So this table 8 here, all of these cancers not in the remaining trial protocol data because they were not included in that statistical analysis. That's how I feel about the BOSS trial. So what do we do with dysplasia? This is going to drive our management. When we find dysplasia, the risk of progression is going to be highest in that high-grade dysplasia group. This is basically carcinoma in situ that will become invasive adenocarcinoma. The annual rate of progression is between 6 to 12%, so at least 10 times greater risk of progression than non-dysplastic Barrett's. And low grade is in this intermediate group, because again, we may not actually be seeing true low grade. This could be a stage where there is prevalent high grade disease, or it is low grade disease, it will not progress over many years. And so those patients require kind of the closest decision making between them and their expert endoscopist. We typically do not recommend any treatment for non-dysplastic Barrett's because the number needed to treat if we were going to do endoscopic eradication therapy on a non-dysplastic Barrett's to prevent one cancer is prohibitively high. So non-dysplastic does not get endoscopic eradication therapy. But if we look at kind of the top 3 guidelines from American GI societies, across the board, high-grade dysplasia, intramucosal adenocarcinoma, we are going to treat with endoscopic eradication therapy. Low-grade dysplasia, I put on here endoscopic eradication therapy, asterisk. And the reason is because most guidelines will say if there is low-grade dysplasia, can consider treatment when balancing the risk versus benefit to that patient. Now, some low-grade dysplasia will not progress. Some will. If your risk of bleeding, perforation, stricture, or other complications from your endoscopic eradication therapy is high, it's not worth putting a patient through endoscopic eradication therapy. However, again, our technologies have advanced quite a bit. These risks are very low. There is pain associated, especially with radiofrequency ablation, which I'll discuss, but in general, these are very well tolerated. And when you have a discussion with a patient about their risk of progression, their risk of undergoing the procedure, and then also the increased frequency of overall surveillance, many patients will consider endoscopic eradication therapy for low grade. There's also several other recommendations that you see in here. Expert GI pathology, referral to high volume center, people who know how to manage these patients well and perform highly effective endoscopic eradication therapy. And then what do you do with visible raised lesions? In general, any nodularity, it's recommended that that is resected. Remaining flat lesions can then be ablated. And that has to do with some of our technologies and the depth of penetration that I'll talk about. So again, if a table isn't for you, this flow sheet comes out of the ASG clinical guidelines to kind of go through what happens when somebody is referred for Barrett's neoplasia or dysplasia. Expert pathology review, repeat high quality endoscopy like Dr. Kolb had done with her patient, resect visible lesions, and then base your remaining treatment on the highest histologic grade of the findings. Is it low grade? Is it high grade? Is it T1A or T1B adenocarcinoma? So we have several options for our endoscopic eradication therapy. Our hot options, these thermal ablative options, they cause acute cell death due to that actual hyperthermic injury and denatures all of the extracellular structural proteins. So radiofrequency ablation has our highest level 1 data in terms of how we can achieve levels of endoscopic eradication of both dysplasia and Barrett's intestinal metaplasia. So this is often our gold standard treatment, especially for flat lesions, as it has a standard depth of penetration and works very well and effectively. There are multiple different paddle types that are shown here. There's also a circumferential balloon if you're doing a circumferential section. So we have several ways of targeting the tissue. Now, argon plasma coagulation, also thermal ablative, is very small for spot treatments. And so this we can kind of use a little bit as a cleanup, especially post-eradication if there are small little islands left over. But in general, radiofrequency ablation is our first line. When we think about our cryoablation options, so this produces cell death in 2 ways. There's immediate and then there's a delayed apoptotic cell death, but it also preserves the extracellular matrix. It's a little less painful for patients than thermal ablative therapy, but the cryoablation has typically a slightly higher stricture rate because it can go a little bit deeper in terms of depth of penetration. That's predominantly with cryospray. So actually sort of spray freezing in sort of a non controlled fashion. You're trying to go based on time, but anybody who has tried this, it's pretty much what it gives you as you are cryoablating the area. Whereas the cryo balloon, which is a little bit newer, but we've been using it and liking it well, it actually has a more standardized dosing, and so depth of penetration is a little bit more stable. The challenge with cryoablation with cryospray is you can get significant barotrauma. So you do need a nasodecompressive tube or oral decompressive tube during treatment in order to suck out any excess gas. Whereas with the cryoballoon, all of it is contained within the balloon itself, so it doesn't have as much barotrauma. And then finally, our resection techniques. So endoscopic mucosal resection with a cap alone, with a cap and band, those are the most common, or ESD, submucosal dissection, where you can take a much wider area and even kind of do big circumferential lesions. Now, EMR is nice for smaller areas or targeting a few areas, especially within a segment where you have nodularity. And as the picture all the way on the right shows, you can take a section and then ablate all of the remaining flat lesions around it. You can achieve the highest technical success because you are actually removing all of the dysplastic tissue, but it's more invasive, higher chance of bleeding, perforation, and strictures related to this. Now, I will say, if you're just capturing one area with an EMR, about 1 centimeter, not a very high stricture rate. If you're doing a circumferential ESD, kind of like the second picture from the right, that's going to be a very high stricture rate. Those patients have differences in terms of their recovery and swallowing afterwards. But all of them work very well. They do require time. So this is a commitment when we're thinking endoscopic eradication therapy. It is not usually just one and done. You to have a discussion with all of these patients, and I'll tell them you are going to be close friends with me for at least the next 6 months before I can get you into high sort of frequency surveillance. We may do several sessions of radiofrequency ablation. We may do several endoscopic resections. And after each one, every kind of 6 to 8 weeks, I am bringing you back and I am looking and I am seeing, is there any persistent disease? Have we eradicated everything? Take biopsies once there's nothing else to eradicate, and then you're getting them back in that surveillance. And at any point, if we don't have adequate reflux control, we may be getting back to the start of this endoscopic treatment. So when we define our endpoints of endoscopic eradication therapy, there's different terminology we use. Complete eradication of visible Barrett's, that's visible columnar-lined mucosa, is different from our CEIM, which is both eradication of visible columnar mucosa and histologic eradication. Complete eradication of dysplasia is just that. You still have columnar line mucosa, you still may have Barrett's intestinal metaplasia present, but there's no dysplasia. We do know that if you can absolutely get rid of all of the Barrett's histologically as well as visibly, you have a lower rate of recurrence of high-grade dysplasia or esophageal adenocarcinoma. And when you ablate, it's critical to also ablate that overlap with the gastric cardia because our cancers are going to start at the GE junction, even though those Barrett goblet cells are going to be all the way at the squamocolumnar junction. So incorporate the cardia into these ablative techniques. So why do we have endpoints and why are those endpoints different? Well, because sometimes when we fail to control that progression or those endpoints, it's because we are struggling with reflux. So uncontrolled reflux exposure is the most significant factor for persistent intestinal metaplasia after RFA or any ablative techniques. Presence of a large hiatal hernia is going to increase risk for recurrence of intestinal metaplasia after ablation, and more than a quarter of patients who are on BID PPI therapy still have abnormal 24-hour pH impedance tests. Weekly acid reflux alone is associated with persistent intestinal metaplasia. These patients struggle to get complete eradication of intestinal metaplasia. We may only get eradication of dysplasia, and those patients are at 3.6 higher risk of developing recurrent high-grade dysplasia or esophageal adenocarcinoma. Part of this is bile. So mixed refluxate, including bile, is highly toxic. We use bile reflux as our model in the lab to induce adenocarcinoma in rats. If you are not achieving eradication of intestinal metaplasia, look back at your reflux control. 94% of patients will achieve complete eradication of intestinal metaplasia after their reflux has been fully optimized. It could just be PPI non-adherence, but it can also be surgical. So, and this comes from it's not just me, gastroenterologists agree. We need to reassess optimization of reflux control. So I'm going to tee this over to our next speaker because I'm going to put in the plug for surgical control of reflux. So we do know, and we have studies that prove that fundoplication is highly effective at preventing recurrence of Barrett's esophagus and allowing us to achieve complete eradication of intestinal metaplasia in patients who otherwise were struggling undergoing RFA therapy. So in conclusion, our surveillance goal is going to be detect early progression to dysplasia so we can treat it before it becomes invasive adenocarcinoma requiring esophagectomy. Goal of early dysplasia detection, again, endoscopic treatment. We are trying to keep people out of that esophagectomy 22% 5-year survival pathway. And if you're unable to get control of Barrett's progression endoscopically, optimize reflux control to escalate care. Thank you.
Thank you, Dr. D'Souza. That was an excellent talk and a great transition to introduce our next speaker, Dr. Brian Louie, thoracic surgeon and the executive medical director of the Digestive Health Institute at Swedish Medical in Seattle. He is an expert in foregut surgery and is going to share some of that expertise with reflux disease and anti-reflux surgery in this context. Thank you for joining us for the webinar.
Well, thank you for the invitation. I'm assuming you can see my slide correctly, yes?
Yep, we can see them.
All right. Thanks to the SSAT and the organizing committee for this. These are my disclosures. As you've heard from the previous two speakers, the pathway to Barrett's esophagus not only requires GERD, but requires bile as part of that reflux. And this is something that has been ingrained upon us for a long time, that bile is one of the key things. And the advantage of surgery and the role of Barrett's esophagus management is that we can control both the acid and the bile, whereas classic treatments of PPIs and even PCABs, they control the acid level only. And so in the next little while, I'm going to try to tell you where anti-reflux surgery fits in the management of Barrett's esophagus. Interesting. I'm not sure how that slide turned out that way, but there are 4 probably areas where surgeons have a role and anti-reflux surgery has a role in Barrett's esophagus. The first one should say something like around symptomatic patients with GERD. The second one we will talk about in terms of managing patients with non-dysplastic Barrett's. We'll get to the area of dysplasia, and we'll come to where Dr. D'Souza was talking about those following endoscopic eradication therapy. When it comes to folks who are symptomatic with GERD and they also have Barrett's esophagus, these are standard patients that all foregut surgeons see, and the surgical selection for these folks is critical. And I remind you of Dr. Campos's work from many years ago that looked at good surgical candidates having an abnormal acid score, typical symptoms, and response to PPI therapy, as those are the key studies that would help us understand who would be a good surgical patient. Now, in 2026, the need for a pH score has been alleviated by some research, though at least in our group, we still will prefer pH studies to set a baseline in preparation for operating on somebody who has Barrett's esophagus. And recently I've had the interesting finding of some patients with cardiac intestinal metaplasia and short segment Barrett's who have normal acid scores. So I still think pH studies should be done if you're going to consider operating on patients with Barrett's esophagus. But the primary goal in this situation still remains GERD control, and how well can we control the reflux as surgeons? And the secondary goal is, can we impact the Barrett's? Because I will show you some data that suggests that perhaps we do a reasonable job, but PPIs also do help, but there is something to suggest we do a better job. I am cautious with patients who have no symptoms of heartburn and acid reflux with Barrett's esophagus because it's hard to make those folks better with surgery. And then the post-surgical objective evaluation for Barrett's, at least in our practice, is if you've had surgery and you have Barrett's, you should expect and will get pH studies after to show that we've controlled your reflux so that we know that we have a successful reflux surgery. The key in anti-reflux surgery is how do we influence the inflammatory condition that creates Barrett's esophagus? And there is some data that is much older that shows that you can reduce IL-8 with anti-reflux surgery. This is work by Dan O when he was a research fellow with Dr. DeMeester, showing that post-anti-reflux surgery, you can reduce the IL-8 characteristics, and IL-8 was higher in adenocarcinoma, higher in Barrett's with dysplasia. But if you operated on folks, as you see in the bottom right graph, post-Nissen fundoplication, you can reduce the IL-8 pathway significantly, suggesting you've reduced the inflammation. At the same time, or around the same time, Dr. Dan Valbomer was doing similar work in the DeMeester lab, looking at COX-2 and looking before and after fundoplication, showing that this marker of inflammation and a part of the pathway for Barrett's esophagus also better controlled after Nissen fundoplication, showing that Nissen does improve the inflammatory markers. And then lastly, a reduction in CDX2 after anti-reflux surgery. Dr. Zaninoto presented this a long time ago at the SSAT as a plenary presentation, looking at patients who underwent medical versus anti-reflux surgery in the fall of a Barrett's esophagus. In there was a little buried section that looked at 69 patients who were CDX positive at baseline. And while there was no change in patients with long segment Barrett's esophagus in their CDX2 status, in the short segment group, 7 out of 13 became CDX2 negative after Nissen fundoplication, compared to 3 out of 21 in the PPI group, suggesting that fundoplication does a better job of reducing some of these inflammatory markers, which are known to drive the development of Barrett's esophagus. Now, can surgery prevent the development of Barrett's esophagus? There are several small studies. This is just one example of only 12 patients to suggest that perhaps we can prevent the development of Barrett's esophagus, but this has really given way more to can we prevent progression and other things as opposed to can we prevent the development of Barrett's esophagus. But one of the bigger studies, and several of them, is this one out of the UK by Dr. Makar, asking, can surgery prevent the development of Barrett's esophagus? And this is a national population-based study out of the UK, and they looked at 4 groups of patients who were 18 and over who had anti-reflux surgery versus no surgery. And in that group, anti-reflux surgery was associated with a reduced risk of esophageal cancer and thus the development of Barrett's. They looked at patients who were 18 plus, comparing anti-reflux surgery versus PPI, where anti-reflux surgery reduced the prevalence of esophageal cancer, but was not really different than PPI therapy. And so when you get to 50, the similar sort of findings, anti-reflux surgery versus no surgery at all or no therapy reduces risk. But when compared to PPIs, there's not much difference in terms of reducing cancer risk or the development of Barrett's esophagus. But can we induce regression of Barrett's esophagus? This is data from a meta-analysis that was done now almost 20 years ago, showing multiple studies showing that, yes, we can regress Barrett's esophagus after anti-reflux surgery. Most of it was short segment Barrett's, cardiac intestinal metaplasia most likely. All of these studies used Nissen fundoplication, and there was a complete loss of IM in 17% of patients. And these are the 4 or 5 studies. There have been about 10 since that time, but that was the indication at the time, almost 20 years ago. Not much has happened in the last 20 years until our co-moderator, Dr. Ayazi's paper came out just recently, hot off the press, where he looked at the induction of regression of Barrett's esophagus. He used Nissen fundoplication and he used magnetic sphincters and the magnetic sphincter augmentation device to look at his outcomes. And ultra short segment Barrett's esophagus, short segment Barrett's esophagus do have a regression rate, but clearly an anatomically intact repair that shows good control of reflux does far better than a disrupted repair in those 2 short sections. Long segment Barrett's esophagus does not really respond to or regress, so probably indicating a much more significant level of disease than short or ultra short. And when he compared magnetic sphincter augmentation to fundoplication, again, there was a rate of histologic correction of Barrett's esophagus in ultra-short and short segment Barrett's esophagus. But again, those are folks that have to have functional repairs and in terms of achieving regression. Can surgery prevent the progression of Barrett's esophagus? So this is even older data. And unfortunately, there's not much newer than this. This is a landmark paper by Dr. Peril out of Spain, looking at folks who had medical treatment, surgical treatment, and successful surgical treatment, meaning that they had reflux control. And if you look at the graph, the bottom part says dysplasia de novo. In medical treatment, 8 out of 40 developed dysplasia, 20%, 3 out of 53 developed, or 6% developed it in surgical treatment that may or may not have been successful. But if you had a successful fundoplication and you had good control of reflux, the chance of developing dysplasia was only 2%, and the chance of progressing from no dysplasia to dysplasia was significantly lower. But this is a small study with limited, well, with potential errors in it because it's a small study. If we look more specifically at when you have low-grade dysplasia or indefinite for dysplasia, can anti-reflux surgery regress cardiac intestinal dysplasia or low-grade dysplasia? This is work on the left by Dr. DeMeester, looking at the length at cardiac intestinal metaplasia and those with Barrett's, and showing that loss of intestinal metaplasia or cardiac intestinal metaplasia occurs in 73%. Loss of low grade, again, 6 out of 9 in the Barrett's group, but 80% of patients with CIM will regress with surgery alone and not necessarily with ablation or with PPIs. And then the Dr. Oschlager's data on the right showing a similar sort of improvement in indefinite for dysplasia and low-grade dysplasia. 53% with indefinite low-grade were found to regress to no IM or no dysplasia with surgery alone. So suggesting again that surgery has a role, that reflux control is paramount in managing Barrett's esophagus. And then lastly, following on Dr. D'Souza's comments, what happens in high-grade dysplasia and endoscopic eradication therapy? And I think this is where surgery does have a significant role to play. She showed you their algorithm every 8 weeks. And then surveillance, we use esomeprazole. But after we're done, we usually do 48-hour pH. We do high resolution. We do upper GI as we prepare for a conversation about will surgery work after endoscopic eradication therapy. Now, I think in Dr. D'Souza's work, you showed some work by Dr. Komanduri out of the University of Chicago. So anti-reflux surgery in the middle of endoscopic eradication therapy certainly can be used to aid in GERD control. And this is an algorithm out of the Chicago group, where in patients who were referred to endoscopic eradication therapy, they had their PPI therapy dose adjusted to BID, and they were, as they were going through, if patients were not healing or they were having trouble or they were still symptomatic, they underwent 24-hour impedance pH on therapy to see if they could be optimized. And if not, they offered the fundoplication to get better control. And so as surgeons, we play a role in trying to help endoscopic eradication therapy. If your GI team is doing it, or if you're doing it yourself, we will use this algorithm to help us understand whether we can impact reflux with anti-reflux surgery. This is work that we did a long time ago looking at fundoplication after endoscopic eradication therapy out of 5 centers. And we looked at the degree of where we were pre-treatment. 92% had dysplastic Barrett's, 8% had non-dysplastic Barrett's. There was low-grade, high-grade intramucosal cancer. 53% of those folks had EMR. They underwent endoscopic therapy, and on repeat biopsies, half of them had no Barrett's esophagus, 33 had non-dysplastic Barrett's esophagus, and 14% had persistent dysplastic Barrett's esophagus. They all underwent Nissen fundoplication, and you can see that after anti-reflux surgery, now we have 73% of patients with no Barrett's esophagus. We have 25% with non-dysplastic Barrett's, and we have reduced that dysplastic group down to 2%. The mean follow-up on this, unfortunately, was short at about 2 years, but as far as I know, nobody has progressed to cancer in this group over time. This is more recent work, still a decade old, looking at fundoplication versus PPI after endoscopic eradication therapy, since in our data we only had a single cohort. But this is a European cohort who compared PPI with Halo and laparoscopic Nissen fundoplication with Halo RFA, showing that overall, when you compared recurrence versus no recurrence, there's much difference between PPIs and the fundoplication in terms of managing the recurrence. But in patients who had 4 or who started off at baseline with 4+ centimeters of Barrett's esophagus, the recurrence with PPIs was 5 compared to 2 after laparoscopic fundoplication. Again, small numbers, but a signal to suggest that better reflux control in folks with more advanced disease probably begets less recurrence. The risk factors, as have been highlighted by other studies, larger hernias, longer length of Barrett's esophagus are concerns for recurrence after EET. And then back to this, these are the 4 areas that anti-reflux surgery has a role to play in Barrett's esophagus. But some cautions. In the Barrett's group, there's a higher rate of motility disorders, there are larger hernias, there is worse lower esophageal function and failure, and there is shortened esophagi. And this leads to a high rate of failure after anti-reflux surgery, for which when recurrent reflux develops after anti-reflux surgery, there is a 3 times increased likelihood of adenocarcinoma. And so the onus is on us as surgeons to select appropriate patients, do anti-reflux surgery well, and make it last, because we are at risk if we do not do a good job. In conclusion, the pathway from GERD to Barrett's and cancer is based on inflammatory changes and involves bile. And anti-reflux surgery has been shown to reduce the key inflammatory markers related to Barrett's development, COX, IL-8, and CDX2. And surgery has a role in preventing the development of Barrett's, though that data is a bit weaker, but certainly stabilizing, regressing, and transforming the trajectory of Barrett's esophagus certainly can be done with good, well-performed anti-reflux surgery that's successful at controlling the reflux. Treatment of dysplastic Barrett's or esophageal cancer, when combined with endoscopic therapy, also can be enhanced with in selected patients who undergo anti-reflux surgery. That's all I have to say. Thank you.
Thank you, everyone. These were fantastic talks. So let's switch to Q&A. We already have a few questions. And for those who haven't submitted their questions yet, please do it so we can go through all the questions. First question, actually, for all the panelists. Dr. Vinit Sada is asking, what is the recommendation for surveillance of non-dysplastic Barrett's after anti-reflux surgery? Can prior anti-reflux surgery be used as a risk stratification marker to guide Barrett's surveillance?
Well, let me start this. I don't change my surveillance of non-dysplastic Barrett's after anti-reflux surgery. I maintain the same usual protocol that I always have. Now, I may differ, but I'd love to hear what Dr. Kolb and Dr. D'Souza do for that.
I'm exactly the same. I don't change my Barrett surveillance based off of my anti-reflux surgery, but I do also agree with your point that once anti-reflux surgery is performed, we do need to confirm that it is effective. So we do standardly perform pH tests post anti-reflux surgery to ensure that we've achieved adequate reflux control. But if a patient has non-dysplastic Barrett's, they're still going to follow the same surveillance timing, and we do use biomarker assay to help guide that for folks, regardless of whether they've had anti-reflux surgery or not.
And the same question, do you keep your patients on PPI after anti-reflux surgery?
If my pH testing is normal, no, I don't. I stop it.
If they have Barrett's. And
if they have Barrett's, well, so I think this is one of the things that is in discussion, and and Dr. Kolb, kind of, you have heard a lot of this. All of us who were at DDW heard the discussions about the utility of PPI as a chemopreventative measure for Barrett's. I don't know that the data is there yet to say that addition of PPI as well as objective confirmation that you have reflux control if that's going to prevent progression. From a surgical standpoint, for most of us, confirming that there is no abnormal reflux with repeat testing after anti-reflux surgery, yeah, usually we will stop PPI. I don't know that we have enough data yet to show that continuing PPI is chemopreventative in patients who already have adequate reflux control, but that's like the next area for us to look into.
Yeah, well, the concern, as you know, Missy, is right at the right at the top of the cardia, where your fundoplication and your esophagus may still be exposed, even though you have a good functioning fundoplication. That's always the issue that I worry about. But I haven't seen any particular problems over time doing that. But I'd love to hear Jen answer some of these, Jen's opinion and perspective on what's been asked.
Yeah, I mean, I think I learned from you guys more that I think typically when they're back in the gastroenterologist, we don't do as much pH testing. We just, if the patient's asymptomatic, we go with that. But I think more often, a lot of the patients that I see, their goal was to get off the PPI. And so if that was their goal prior to surgery, I'm not going to add it back in for the, like you said, the potential small chemopreventative effect that we're not even sure about.
Yeah, I mean, I think a lot of good points, and especially what Dr. Kolb just mentioned is sometimes the patients guide this discussion more than anything because we don't have a lot of strong evidences. We've talked about after anti-reflux surgery for surveillance and PPI use. I mean, for me, the patients guide a lot of this because they have gotten the anti-reflux surgery for some reason, but I do still encourage surveillance as well. I think the PPI I really let the patient guide that discussion, and often I stop it. I have a question for the group, unless we have more Q&As, do we?
I think
There
there's
are a few questions, yeah.
Okay, go ahead.
Yeah. There's a question about Barrett surveillance and EET for rural surgeons. A question for Dr. Kolb.
Oh, that's a really tough question. So how do you get your patients adequate surveillance and treatment in poor resource settings? I mean, I think upfront it starts with education and like a really good, I mean, you really have to sit down a patient with Barrett's and make sure they understand what it means. I think we probably could do better about having that first clinic visit. And I think the patient has to understand that there's a chance for development progression to cancer, that this is a precancerous condition. This isn't something that we're just recommending like, casually. And this is really, I think, where biomarkers are actually most helpful. So if you can get them in for one test, and you can get some risk stratification and it's low risk, I think you can feel reassured, even in potentially a case of a low grade, that potentially surveillance is going to be better for them. But if it's high risk tissue cipher, for example, then I think that really will push you to be more aggressive about trying to find resources. I wish I had better advice, though, on sort of where to get the resources. But like Dr. D'Souza mentioned, it is quite a journey to commit to endoscopic eradication therapy. And that's a big deal. And that takes a lot of time and effort every 3 months for at least 4 or 5 sessions usually.
Yeah, so, I think the challenging part, Jen, as you said, is if you have non-dysplastic Barrett's and how are you going to survey them and get them in? And then if you have low grade. But I think it's an easier conversation if they have a mucosal cancer that you can endoscopically resect and whatnot, because if I have patients in rural Montana, rural Alaska, they don't want to come back and forth. They will take esophagectomy, even though it's a one-stop shop. At least they know it's out, it's cured, and they're done. And so I still think there's a role for esophagectomy in early stage mucosal cancers, high-grade dysplasia, for folks who cannot commit to EET. Clearly, endoscopic eradication therapy is far superior to then doing an esophagectomy on those folks, but we have seen a number of recurrent cancers after patients who have failed to show up for their ongoing therapy, their surveillance, and those cancers are particularly problematic at that point in time. And so that's a long conversation. I think surgery and GI should be in on that conversation with folks who cannot attend and follow the aggressive nature and the labor-intensive nature of endoscopic therapy.
So there's a question for both Dr. D'Souza and Dr. Louis. Dr. Ali is asking about timing of EET in relationship to anti-reflux surgery, and whether the timing before or after anti-reflux surgery may have any impact on regression or less progression.
Well, good question. Missy, do you want to go first?
I can go first. Particularly because you're asking about low-grade dysplasia, where some folks wouldn't even ablate that. They'd follow that for progression. I think before any surgery on any patient with any Barrett's dysplasia, they're getting that repeat endoscopic exam. And usually at that time, I find that we're often doing some kind of endoscopic eradication therapy, whether we find a subtle nodule and we resect it, or doing some kind of ablation. The challenge becomes, this is what Dr. Louis was mentioning, the highest risk area for cancer is the GE junction, which may still, that gastric cardia is more exposed at the bottom of your fundoplication. So you're still following this actually quite closely. We've had some patients where we have, and you have to counsel these patients very well. We've ablated them at the same time that they are having their anti-reflux surgery. Some of these patients coming from more rural areas where, they have low-grade dysplasia, but with high risk factors for progression. We ablate them at the same time as their anti-reflux surgery. Their recovery is delayed because they've got additional edema in that area. And we're doing close follow-up. But I think, again, this is a pretty close discussion between surgeon and GI in terms of timing, especially if you, depending on whether the GI who's going to be following their Barrett's ablates low grade or not, or leaves it be. I don't know. What else do you have to add, Brian?
Yeah, I think for low grade, I tend to prefer, or I'm a little bit slower to move to endoscopic eradication therapy. I'd like to see PPIs optimized. I'd like several endoscopies to prove that this is low grade that sticks around, because I certainly have had patients where we've optimized PPIs, we've gone back and rebiopsied them and found no low grade, and that's with the Watts and pinch biopsies, and found no low grade, and then watch them over time, and only to have the low grade come back, and then we've ablated. So low grade is so variable to me that I think I'm a little bit slower to sort of go to EET so that if I can control them with PPIs and it goes away, then I'm more likely to give them anti-reflux surgery if they're still persistently symptomatic, before I would endoscopically eradicate them based on Dr. Demeester and Oschlager's data.
Yeah.
And I think, if you're asking about high grade or mucosal cancer plus high grade, it is, to me, always endoscopic eradication therapy first. Prove on biopsy that you've got complete eradication, both the dysplasia and the Barrett's, and then I wait and survey them for a while, because some people will recur, as everybody knows, and then you're still treating them. So I prefer to do the anti-reflux surgery well after the fact of a bit of surveillance, especially if you have high grade or mucosal cancer plus high grade, because don't want to do a Nissen or a fundoplication and then be short and go, oh shoot, this guy's going to progress and we got a problem. So
Yeah, exactly. I think completely eradicating any high grade and mucosal cancer, intramucosal cancer comes first. I do want to say, because we've been, I think I have the fortune, and maybe Dr. Kolb and Dr. Louis are the same, of oftentimes having expert GI pathologists who have already reviewed this low grade dysplasia. So that's the other caveat, is depending on who did the biopsy to find the low grade dysplasia, that can be pretty tricky, and the diagnosis of low-grade dysplasia is often overturned on expert GI pathologist review. We see similar things with indefinite for dysplasia. If somebody has pretty significant esophagitis, those cells look atypical just from the severe inflammatory disease. So again, where it's a really good high-quality exam, expert GI pathology review is helpful anytime there's any question of dysplasia.
Okay, there's a question for either Dr. Kolb or Dr. D'Souza. Are there patient population for whom current guideline recommendation may be too conservative or too aggressive?
Probably is the short answer. I think, guidelines use the best data that we have from large cohorts and try to make recommendations that apply to everyone, but they're very general. So are they too general or are they too aggressive or too lenient? I mean, I think this whole 3 to 5 year surveillance for non-dysplastic, it kind of exemplifies that, right? So most people, if you look at like GI Quick data, national GI quality registry data, majority of people bring back non-dysplastics at 1 to 2 years. That's actually kind of the mean. So most people are bringing them back too soon, aren't even waiting 3 years. I think a lot of people are not really adhering to segment length and bringing everybody back at 3 years. Most people are nervous about waiting 5 years. So yeah, I think there's probably a lot of opportunity for refining our guidelines, but we just haven't seen we haven't had the enough data to really support that yet. Um, I think once we incorporate some of these new tools, when we have stronger data and start incorporating them, that's where I think we're really going to see a paradigm shift, right? And again, like I also think that there will be at some point an approach that matters longitudinally, right? So a person's risk today is may be different at their whether it's their index exam or their subsequent, depending on their biology at that time.
There's another question again for Dr. Cole. How are you currently incorporating TissueCypher into your clinical practice, and in which patients do you find it most helpful?
Yeah. So I use TissueCypher for the majority of my histologically low risk patients. So patients who come back as non-dysplastic, and actually in particular in the indefinite and low grades where I will make it actionable. I use that caveat because it's not worth getting a test just for information. Like I think it really has to somehow impact management. And so in particular in the indefinites or the low grades where there's been discrepancies on prior, we're looking for an excuse to maybe elderly patient, anticoagulation, lives far away, right? There would be a lot of benefit in having a low risk score that would push you to a sort of more conservative approach. And then I use it in short and long segment of non-dysplastic. Again, I think some of the data that I showed indicates that we don't really know. We can't really distinguish between it. So I use it in all of those, in all my non-dysplastic, indefinite, low grade. I'll just mention it's covered entirely cost-wise, so the patients won't have to pay for it. Medicare covers it at 100% as well.
Let me ask Dr. Kolb a question, follow up on TissueCypher, because I've wondered this, in a long segment of Barrett's esophagus. So you have C10M10 and you're biopsying. What do you send off for TissueCypher? Which level? Do you send them
Yeah.
all off? Do you send one of them off? Do you send the top end, the bottom end, the middle?
Yeah. So I think this is usually predetermined with the pathology lab and the way Castle does the requisition, but they'll typically request for a short segment 1 level and for a long segment 3 levels. And it'll generally be the default if you don't specify the top, the middle, and the bottom. So the goal in that sense is that there have been some studies to support that TissueCypher kind of acknowledges and appreciates the field's effect. And so even up to 2-3 centimeters, it can capture the molecular signal. And so if you have 10 centimeters and you get top, middle, and bottom, you're basically getting within a few centimeters of the entire segment. If I do a targeted biopsy of something nodular that comes back as non-dysplastic and I don't feel great about it, that might be what I specifically indicate.
Interesting. Okay.
But no one's asking, but I'll just mention a question that I always wonder, like, so how long till, like, if you get an intermediate, right? How long? When do you do surveillance? So there's no, this is still up for discussion. Sooner, right? I think we'd say sooner than 3 years. Whether it's going to be at 6 months or at 1 year, I think depends on how good your index exam was. Are you really trying to rule out prevalent dysplasia, or do you feel really confident in that exam? And maybe instead of going 3 years, you go about 1 year. But that's really, I think, still evolving.
Yeah, I think that's an interesting question because if it's the first time that we've identified Barrett's and made the diagnosis and it comes back intermediate, then to me it's going to be a 6 month because I'm worried about prevalent dysplasia. If I've scoped them several times and all of a sudden I picked up intermediate, like it's changed, I might go, I might feel better about a year. But still, I worry that we're going to be missing something, right? And so And then for, you know, for high risk, what do you do for that? Because usually that's been an interesting conversation. I've had folks say, I need to be ablated because I have long segment, they have lots of risk factors, or do you want to watch them in a year? What do you do for the high risk folks with tissue size?
Yeah, I agree with what you said about the other groups. For the high risk, I offer them endoscopic eradication therapy. And I really look closely for something to EMR. And I've had mixed. I mean, I haven't had so many high risk. We don't get that many, but it's been a little bit of a mixed bag. Some patients just want surveillance. They don't want to go through because once you start, you're really doing all the therapy. And so it's surprising sometimes patients are more willing to come in for frequent exams than necessarily for all the treatment. But I'll offer it.
Okay. That's not far off from what I do either, so that's good to know.
And we have time for the last question. This is for Dr. Louis. Which Barrett patients do you believe benefit most from anti-reflux surgery?
Which patients with Barrett's benefit most?
Yeah. So you have a lower threshold to offer anti-reflux surgery.
Because it's about reflux control, the folks who are well controlled on BID PPIs, who probably have some dysmotility and whatnot, I don't know that they are as beneficial. Whereas the patients who have longer segments, who are very symptomatic, poorly controlled on PPIs, those folks, I think, they're the hardest patients to operate on because they have a lot of issues with their motility and their functionality. But those folks actually, I think, benefit the most if you can get successful surgery done, pH control after, and prevent them from having a recurrence. Those, I think, are the ones who benefit the most because they have the most disease, and the need to control the reflux symptoms is better. That's one way of looking at it. But if we are going to make an impact on preventing cancer, it's probably the earlier disease that you actually will probably make the most impact on in terms of preventing them from progressing from Barrett's to non-dysplastic to dysplastic to a cancer. It might be the earlier disease ones where it hasn't taken a hold yet, and you actually can alter the trajectory of the Barrett's esophagus. So, tough question. Not a lot of data, Sheen. I'd be curious to see what you think and what Missy thinks, and Yelini, about that same question. What do you guys do? What do you think will benefit the most?
So I would rephrase the question. If there is any Barrett patient that won't benefit from anti-reflux surgery in terms of oncological outcome. So if the patients with a very long segment, our data show that long segment patients don't have any oncologic benefits. So the surgery is primarily for correcting the anatomical abnormality, symptom control, quality of life.
Yeah, I mean, I'm going to put my plug in here especially because Dr. Kolb mentioned this, with every 5-point BMI increase, your 6% increased risk in progression, we have very large people in the United States. There are some patients where if you're talking about somebody who's got BMI of 50, BMI of 60, their best anti-reflux procedure is probably going to be a gastric bypass and not a fundoplication, with the caveat of you do a gastric bypass, not a sleeve, so you save the remnant stomach. So if they did develop esophageal cancer, you have a conduit for them, but you're improving kind of their oncologic outcomes in that standpoint, because if you can get them surgical weight loss, then you're reducing their risk of multiple different cancers, not just Barrett's progression. So I would say that's a patient population to also think about when you're thinking about Barrett's management in the morbidly obese and super morbidly obese folks.
I completely agree with you about the principle. There is very limited data on the oncoprotection of the bariatric procedure in Barrett population.
Yeah, we really haven't looked at it that much. And I think part of it too is so many patients who get bariatric procedures tend to be younger women who are traditionally not patients that we consider to be at risk for Barrett's esophagus. And yet, there are studies out there that show that if you do biopsies at the SCJ of these folks, many of them have cardiac intestinal metaplasia, which will regress. Now, is it regressing just because you have excellent, reflux control, or was it going to regress anyway? We don't know. But I think that's one area that we should look into, especially as so many bariatric procedures have been performed and will be performed as GLP-1s wax and wane, that it's critical to think about the Barrett's ones.
All right. Yelena, do you have anything to add to them? These were fantastic talks. We are almost over our time.
Yeah, I was just going to say this is a terrific webinar. I think it's recorded as well. So if anybody wants to pass it along to others, I think it's available. Correct, Shaheen? And again, this great talk. There's so much to talk about, and we fit so much in such a great amount of time. So thank you to all the speakers for being efficient and effective with your time and a great Q&A.
All right.
Thank you.
Sounds good. Thank you, everybody.
Thank you
Thank
so
you.
much.
I appreciate it.